I'm going to be talking about brain tumors, and I think most of you are aware that WHO has 120 different types of brain tumors, and I think I'm going to show about 100 today. So not quite the entire 120, but I'm going to actually stay very faithful to the core study guideline. I'm only going to talk about tumors that are mentioned in the core study guideline and follow the format of how they are supposed to, they're recommending you study brain tumors. So the ABR core guideline states that the tumors should be studied based on the 9 locations, and it also lists 34 different types of brain tumors. So I would like to at least show you some of these, but please remember this is not a session where you're gonna be taking any notes. I just want you to look at the images and listen to me now, and then you can learn about it later. But this is more of a pictorial essay. And it's gonna be a rapid fire of different cases, types of tumors that I'm gonna show you. And hopefully you will get a good sense of sort of a good general overview as opposed to going very in detail about one specific entity. So let's talk about the 9 locations. So first, the 6 most common locations where you're gonna see brain tumors is the parenchymal, meaning the tumor came from the brain substance itself. Meningioma being the most common, obviously, comes from the covering. Intraventricular, self-explanatory. Tumor comes from within the ventricle or within the choroid plexus. Cellular, supracellular, that location has a whole set of different differential diagnoses. Pineal gland and CP angle. And here are the 6 representative tumors that are most common. One of the most common parenchymal tumor is the glial neoplasm. Metastases will be also in this category. By far, meningioma is the most common primary brain tumors. Choroid plexus tumor is probably one of the most common intraventricular tumor. Cellular, supracellular, number 1 pituitary tumor. Pineal gland, germinoma or pineal parenchymal tumors. CP angle, schwannoma, but also in it is meningioma. 3 more locations. Skull base, probably the central skull base involving the clivus is one of the most common things that we run into. Cavernous sinus, foramen magnum. Chordoma being the most characteristic location within the clivus. Meningioma or lymphoma or schwannoma within the cavernous sinus. And foramen magnum, we often see ependymoma as well as subependymoma. Ventrally, we often see meningioma as well. So those are the 9 locations. Now, tumors by behavioral issues. So we have at least different spectrum of malignancy within the brain tumors. So here are the 4 different categories of aggression. By looking at this, you already know that that's most likely going to be meningioma. So that is the good. I put asterisks there because meningioma in like orbits, cavernous sinus, even the biology is good, the location is terrible. The bad, you could just look at that tumor and know that that is a bad acting tumor. And here's a non-enhancing tumor. So I say undecided because these lower grade gliomas can turn into glioblastomas and behave terribly, or they may stay lower grade for some time. And the wannabes, here's a lipoma. These are not truly tumor, so these are what the core guideline considers as a tumor-like condition. The most common, 3 most common type brain tumors that we see every day at a major institution is these 3 entities: metastases, meningioma, and glioblastoma. So if you consider the parenchymal tumors, by far metastases and GBM will make up probably 80% of what you see every day. If the tumor is located outside of the brain parenchyma, it's going to be meningioma. So what kind of imaging technique should you use? Both CT and MRs are both used. At our institution, when patient first comes in with seizure or signs of hydrocephalus, they're going to get CT. CT is an excellent test to rule out 3 H conditions, and they are hydrocephalus, hemorrhage, and herniation, and that's it. CT should not be the mainstay of working up a brain tumor, then that includes contrast-enhanced CT. So CT is only good for ruling out 3 H's, hydrocephalus, hemorrhage, and herniation. But here's a perfect example why CT is not a good test to look for cancers or tumors, something very bad in the brain. Here's a young woman coming in. She has a little signs of hydrocephalus. She's not feeling well. All we can say about this CT without the benefit of having prior study is that the ventricle looks a little big, but that's really all we can really say. Now, some of you who are really astute may notice maybe a little hyperdense possibly here, maybe a little denser here, but these are, you could stare at this for 3 hours and you may not be able to precisely say what is going on. So we did not like the fact that this young woman with a remote history of breast cancer has evidence of hydrocephalus. The next test, we obtained MRI 6 hours later, same day, and you could see these multiple nodular leptomeningeal carcinomatosis that is best depicted on MR. And even using a retrospectoscope, I really have a hard time seeing these really ugly, lumpy leptomeningeal disease on a CT that was done 6 hours earlier. That is why MRI with contrast is the test of choice for brain tumor, including leptomeningeal carcinomatosis. At UCSF, this is our standard brain tumor imaging protocol, and I stress the fact that before you look at post-GAD, you have to look at pre-GAD to make sure that you're not calling something enhancing when it is already bright to start with. FLAIR obviously plays a very important role. MPGR, SWI, or ISI, SWAN, very important to look for blood products. Diffusion, essential, because that's where we pick up pus in the brain or stroke, unsuspected infarcts. So DWI is also an essential part of brain tumor imaging protocol. Here's why you must look at post-GAD imaging with the pre-GAD imaging. This patient came to us from outside as saying homogeneously enhancing cellular supracellular mass, most consistent with pilocytic astrocytoma. And when we actually looked at the pre-GAD looked just like the post-GAD. This is not a homogeneously enhancing mass at all. The mass is likely cystic that contains either blood products or highly proteinaceous material. If you look at sagittal view, this actually comes from the cellular supracellular. This is a adamantinomatous craniopharyngioma, not a solidly enhancing pilocytic astrocytoma. So you must look at post-contrast imaging alongside with the pre-contrast. So intraparenchymally, the 3 types we already talked about, glioma, metastasis, and lymphoma. Those are the 3 most common intraparenchymal tumor. At our institution, because we have a specific referral pattern, we see a lot of glioma. Here is a patient with glioblastoma. We see 2 separate lesions. Pretty unusual to have 2 separate sites of GBMs, but because we see so many of these patients, we often see these multifocal GBM. You might want to consider metastasis here too, because there are 2 tumors there. But nonetheless, these 3, metastasis, glioma, and lymphoma, make up vast majority of our intraparenchymal tumors. And here's an example of a glioblastoma. Here's a renal cell metastases, all intraparenchymal, and there is that solidly enhancing CNS lymphoma. In a child, the intraparenchymal tumors, the 3 most common type, actually the 2 most common type is pilocytic and ependymoma. And I'm gonna just touch on this tumor, ATRT, atypical rhabdoid tumor. This is probably one of the worst, most aggressive tumor that I've seen. And it usually is limited to pediatric age group. It's a devastating tumor. And you look at it and you know that this tumor is coming from the parenchyma and basically destroying the parenchymal margin. And compare that to this nice, well-circumscribed nodule and a cyst of a pilocytic astrocytoma. There are 4 types of gliomas: astrocytoma, oligo, ependymoma, and choroid plexus tumor. So let's talk about these. Gliomas, the 4 types, as I said, astrocytoma, glioblastoma being the most common of the astrocytic tumors, oligodendroglioma, ependymoma, and choroid plexus tumor. And the only thing that I would like to kind of mention here is that ependymoma When it occurs supratentorially, it's an intraparenchymal tumor. When ependymomas occur infratentorially, they are intraventricular tumor. No one really knows why there's a difference. Same goes for a CPP tumor. When CP choroid plexus tumor occurs in pediatric age group, they have a propensity towards the lateral ventricle, whereas in adults, choroid plexus tumor is almost exclusively seen within the posterior fossa. Of the the astrocytomas, I already alluded to the fact that glioblastoma, or grade 4, is unfortunately the most common, but we have grade 1, pilocytic. This is the best kind of astrocytoma. The grade 2, non-enhancing, could be good, could be bad. If these are, they could rapidly turn into anaplastic astrocytoma as well. Grade 3, clearly not as good as grade 2. This anaplastic is probably on its way to GBM. And if you look at T2 characteristics, here's T2 and a flare, difference between grade 1, 2, 3, 4. You'll see that as the grade of tumor increases, the amount of edema increases, as well as the degree of heterogeneity within the mass itself is also increases. So here's a nice grade 1 tumor, circumscribed, almost no edema, whereas here's a tumor. The tumor is not that big, but look at the amount of edema. So these are grade 1, the good, grade 4, the bad. Oligo is a special kind of glioma. We now learn a lot more about these tumors. These tumors like to expand the cortex, but this is the particular tumor that has that unique chromosomal abnormality where there is 1p, chromosome number 1 and chromosome number 19 has a very specific chromosomal loss, so-called 1p19q loss. And if an oligo has 1p19q loss, those are actually the better prognostic subgroup. So here, oligo tends to affect more younger patients. It's a better prognosis than astrocytomas, often frontal lobe, often contains calcification. Here's an example. So oligo on CT often misdiagnosed as AVM, and you could see why. They have this serpiginous, almost vascular-looking calcification. But once you get an MRI, you know that this is not a vascular malformation, but rather there is a big infiltrating mass, cortically expanding, and there is this serpiginous calcification. This is virtually pathognomonic of an oligodendroglioma. I alluded to the fact that ependymomas, when they occur supratentorially, they are intraparenchymal. When they occur infratentorially or within the posterior fossa, they tend to be intraventricular. And here's a child with one of the largest ependymomas I've seen. So when the mass gets this big, sometimes it's difficult to know where did it come from. Is it in the ventricle? So this is a path-proven, all intraparenchymal ependymoma that's pushing on the ipsilateral ventricle and trapping the contralateral side. Lymphoma is an interesting tumor. The rising incidence is unexplained, particularly in the immunocompetent patient, but we see maybe 2 or 3 lymphomas per month, and that's unusual. It's incidence in the rising and nobody really knows why. But the key to identifying lymphoma is the T2 signal characteristic. Because of their cellularity on T2, the tumor is low signal intensity, almost isointense to the brain matter, as opposed to glial tumors where the T2 characteristics are more closer to the CSF signal intensity. Here's both glioblastomas and lymphomas favor corpus callosum. By looking at the post-con alone, you may not be able to differentiate the two. But usually GBMs tend to have larger area of necrosis, whereas lymphomas are more solid tumor. But if you look at the T2, you'll see the difference right away. Here's a highly cellular tumor, showing lower signal on T2. Here is a necrotic GBM showing you very high signal intensity. Brain mets, these are pretty straightforward, multiple, but up to 30% of brain metastasis could be a single lesion. So I've seen 10 centimeter brain metastases. So just because there's one mass does not exclude metastases. But fortunately, most of the metastatic cancer looks like this. There are multiple intraparenchymal masses. And this is that lady, 42-year-old lady with breast carcinoma that I showed you. This lady had basically nodular leptomeningeal carcinomatosis that was basically non-visible on CT. Moving down to the infratentorial brain, there are two types that I want you to remember: hemangioblastoma versus metastasis, but by far, metastasis is going to be the most common just because there are a lot more patients surviving systemic cancer and they're going to have metastases. Whereas hemangioblastoma, whether they're related to von Hippel-Lindau or not, is a pretty rare tumor. But they tend to have a very characteristic imaging features in that they have a peel-based nodule and a cyst. Whereas metastatic carcinoma will be these solid, small, nodular enhancing masses. Now, here is a melanoma metastasis, but I draw your attention. When you see a bone destruction, dural invasion, you should think of metastatic carcinoma. Almost never have I seen a glioblastoma invade the bone. Never seen it. So when you see bony destruction, dural invasion, as well as extracranial involvement, metastatic cancer should be on your top 10 differential. Glioblastomas do not invade the bone. Just doesn't happen. Meningeal, this is pretty straightforward. Meningioma is going to be your number 1, number 2, number 10 choices. But metastasis, as I said, here is a child with neuroblastoma metastasis, dural location. And here is a tumor-like condition, epidermoid. It's not really a tumor, but nonetheless, it's in the meningeal or extraaxial compartment. Meningiomas are very well known on an angiographic appearance where they have an early capillary filling and delayed washout. But we don't really need angiogram to diagnose meningiomas. We could actually, look at MR and know that meningiomas almost have an identical signal intensity to the brain parenchyma on both FLAIR, T2, PreGet T1, and they enhance avidly. Now, the degree of edema associated with meningioma has nothing to do with whether it's going to be a typical grade 1 versus atypical grade 2. I have seen plenty of grade 1 meningiomas causing enormous amount of edema. So the edema in meningioma has nothing to do with the aggressiveness of it. Intraventricular, I just stressed that point again. The most common intraventricular tumor that we see often is the CPP, choroid plexus tumor, but it has a very different age distribution. In pediatric age group, they favor the lateral ventricle. CPP favors fourth ventricle or fourth ventricular outflow tract in adults. Meningioma, the classic location is the atrium or the trigone of the lateral ventricle. But remember that central neurocytoma loves to occur in the lateral ventricle. So let me show you a couple of examples. Here are the 3 most common types of intraventricular tumors that I see at UCSF. Meningioma, if the location is in the trigone, that's virtually pathognomonic. Although recently I saw a gastric metastases to the choroid plexus of the atrium. Pretty unusual, but that was path proven. But when you see an atrial tumor, intraventricular meningioma should be your top differential. Here is a temporal horn intraventricular tumor, lobulated. This is a choroid plexus papilloma in a pediatric age group. And here's a tumor adherent, inseparable from the septum pellucidum. That's a pathognomonic central neurocytoma. Just to show you a couple more examples of the trigonal or atrial intraventricular meningioma. Very characteristic location. Couple more examples of lateral intraventricular tumor. The most common is, this is the one I see. Central neurocytoma can be avidly enhancing or minimally enhancing, but the key here is that they are inseparable from the septum pellucidum. Now here's an ependymoma, but I just told you ependymomas supratentorially are intraparenchymal. This Although it looks like intraventricular, at surgery, it was an intraparenchymal tumor pedunculating and herniating downward into the ventricle. So you might also want to consider an exophytic tumor within the lateral ventricle, possibly as a intraparenchymal ependymoma herniating downward. Here's more classic subependymoma, which is truly intraventricular in location. Here's often discovered after some minor car accident. This was the case for this individual. There's a little mass right at the obax, the opening of the central canal, and that is pretty classic for subependymoma. Obax is the key anatomical landmark to know that that is the favored location where the fourth ventricular subependymoma. So subependymoma, consider a very nice version of the ependymoma. These are very benign tumor, but often they do get taken out just because of the location. They may actually cause obstructive hydrocephalus if they get big enough, but usually these are very soft tumor, very benign tumor. And here's sort of more angry looking cousin of the subependymoma, and this is ependymoma. Like I said, ependymoma in the posterior fossa is an intraventricular tumor. Ependymoma supratentorially is an intraparenchymal tumor. Cavernous sinus tumors, I already showed you, but one thing that you do not want to miscall here is the aneurysm. You do not want to send your surgeon with a cavernous sinus mass that is actually a huge giant aneurysm. You're going to have a very angry phone call. So always think about the possibility of an aneurysm, but luckily we tend to see meningiomas, schwannomas, lower grade tumor, but we see hemangioma there too. And the cavernous sinus anatomy, because there's lots of cranial nerve, schwannoma is one of the common things that we see there. Here is a small, subtle case of cavernous meningioma. And I draw your attention to the T2 characteristic. So the biggest difference between meningioma versus, let's say, hemangioma in this location, you'll find it on T2 weighted imaging. Hemangiomas are bright, bright, bright. Meningiomas are dark, dark, dark. And here is the angry cousin of the meningioma, which is called hemangiopericytoma within the cavernous sinus. And here's a tumor, looks very bright. That alone, you should stay away from calling this meningioma. I just showed you meningiomas on T2 weighted imaging is going to have a similar signal intensity as the brain. So that alone, you know that this is not likely to be meningioma. Here's a CT. So patient has a tumor that has two different characteristics, but the one that is hanging into the prepontine cistern is partially calcified. But the tumor that is involving the cavernous sinus is fairly bright. Anything bright, you should think about hemangioma, chondroid tumors, chondroma, or chordoma. And this is a path-proven chondrosarcoma of the cavernous sinus. And this is a cavernous sinus chondroblastoma. That's pretty unusual. But again, you'll see that this shape is kind of wrong for meningiomas. Meningiomas tend to be dural-based. And here's sort of T2, how that's really important to help you make the diagnosis. Pre-GAT T1, T2, post-GAT T1. So you know this is an avidly enhancing mass. You go to your T2 weighted imaging and you know that this is not going to be meningioma because it's so bright, almost as bright as CSF. And that is actually one from literature. This is a hemangioma of the cavernous sinus. And this is actually from the one literature showing the same thing. Look at the T2 characteristic of this cavernous sinus mass. Very bright, homogeneously enhances, and this is a hemangioma. So T2, very important to differentiate meningioma versus other non-meningioma tumors. And I show you that, again, the difference between hemangioma and meningioma signal characteristic on T2 weighted imaging. This is a perineural spread of tumor going out into from cavernous sinus to the foraminal valley. And just to finish up the adult posterior fossa tumors, ependymoma, subependymoma, chorioplexus papilloma, I already showed you the example. Like I said before, CPP in adults, exclusively occurs in the posterior fossa in and around the fourth ventricle. In a child, posterior fossa tumors, the three most common types are here, medullo being the worst in terms of biologic behavior, pilocytic being the best. Pilocytic almost always has this sort of appearance of nodule and a nice-looking cyst. Somebody asked me, how do I know that that's not hemangioblastoma? The characteristic hemangioblastoma nodule is usually peel-based, as opposed to pilocytic nodule is deep within the deeper margin of the tumor itself. And medulloblastoma, like I said, is the most aggressive posterior fossa tumor in children, and they also tend to be disseminating along the CSF, so you really have to pay attention to the post-GAD imaging elsewhere because they like to spread via the CSF. And here's some of the tumors that love to spread along the subventricular margin or CSF, medulloblastoma being the most common that we see at our institution, but this type of spread can be seen in PNET, pineoblastomas, germinomas, ependymomas rarely, but sometimes CP, choroid plexus tumors can also, because they're already in the CSF swimming, so it's easy for them to spread along. Cellular, supracellular tumors. So here I just want to make sure that everybody knows the very basic anatomical landmark of the adenohypophysis versus the neural hypophysis. And there's a little bit of a adenohypophysis tissue called pars tuberalis that's hugging the infundibulum. And once you know the anatomy, the key, whenever you see a cellular supracellular mass like this, the key is to locate the pituitary gland. And here it is. In real life, pituitary gland is not going to be green, but once you locate that, you know that that is not a pituitary origin tumor. This is a pre-GET T1, very, very bright. That's a lipoma. This one, the tumor is above, has nothing to do with pituitary gland, does not enhance, follows the gray matter signal. That's a hamartoma of the tuberous cinerarium. And this is a cellular supracellular, primarily a cystic. There's no nodular component, so Rathke's cleft cyst has to be on the top differential. And here's the most classic cellular supracellular solid mass, and that's a pituitary macroadenoma. And you look at this entity and say, well, that kind of looks like this entity, except that it's a little fuzzier border. You need history. This is a recently postpartum woman with a severe headache, and that is a lymphocytic hypophysitis. So you really have to put the history together before you go down the path of recommending calling a pituitary macroadenoma. So like I said, lipoma, hamartoma, Rathke's cleft cyst, pituitary adenoma, and lymphocytic hypophysis. This is your main 5 differential in this location. Now, there's some tumors that could occur there as well. Optic glioma, pituitary adenoma I already showed you, but also tuberculum cellae meningioma can occur there. However, usually there is a little visible pituitary gland. So if you see pituitary gland that's normal but pushed away, pituitary adenoma is not a possibility. Here are the more aggressive cellular supracellular germinoma, craniopharyngioma, and lymphoma. So germinoma can spread, like I said, similar to medulloblastoma, swim along the ventricular margin. Now, pineal gland, there are 3 tumors that I want you to remember. Pineoblastoma is the worst, pineocytoma is the better, and the germinoma is sort of in between. And this comes up time to time. How do you differentiate germinoma versus pineoblastoma? This is a real problem because they can look very similar. And the literature will tell you that, and we've actually, myself have been helped by the CT, where if you look at the calcification in relation to the mass, the pineal tumor, they came from the pineal gland, the calcium is pushed out, or exploded fashion, or peripheral fashion, or pineoblastic fashion. So here is the best type of pineal tumor called pineocytoma. You could see the calcium is in the periphery. This is the pineal parenchymal tumor of the intermediate differentiation. Again, the calcium is in the perimeter, not within the mass. This is the worst kind of pineal tumor called pineoblastoma. And you could see, at least people argue that the calcium is kind of blasted or exploded. Whereas this last example, the calcium is engulfed. That's the germinoma. So if you remember, pineoblastoma has the explosive, exploded calcification pattern versus the germinoma, which is the engulfed calcification pattern. Just to finish up, CP angle, pretty easy here. Arachnoid cyst, epidermoid. The only way to differentiate the two is diffusion-weighted imaging. If they are avidly enhancing masses, and if they're going into the IAC and patient has a hearing loss, that's going to be vestibular schwannoma. And meningioma usually has a broad-based, dural-based nature. And there may be a little bit of dural tail going into the internal auditory canal, but usually patients presenting symptom is not going to be hearing problem compared to the schwannoma. And here's the diffusion-weighted imaging of epidermoid cyst showing the reduced diffusion compared to arachnoid cyst, which is not going to be reduced. Finish up with the skull base. I think the main thing that I want you to remember is the clival chordoma. But if you just look at post-scat, it could be tricky. Could this be meningioma, or it could be something else? So you really have to go to, and the enhancement may not be very avid in chordoma, but I find the T2 weighted imaging of the chondroid tumor the most helpful. Similar to the hemangioma versus meningioma comparison, if you look at chordoma on T2, they are going to be almost as bright as the CSF. And that's really the clue that you are dealing with chondroid tumor. And here's an example of that. And here's again, the T2 of a chordoma looking almost as bright as CSF. Last category, foramen magnum. This is the location. Sometimes we see not tumor, but most commonly we see these herniated tonsil in a situation of a Chiari malformation. But at our institution, we often see patients with spontaneous intracranial hypotension, also presenting with this drooping down tonsillar mass at the foramen magnum. But the mass, the brain tumor that occurs there, like I said, don't forget your obex. That's the opening of the central canal, subependymoma, very commonly seen. But there are other masses, meningioma being, again, the most common. They could occur ventrally, they could engulf the vertebral artery, but does not necessarily decrease the lumen, and they could look like a huge mass. This is an ependymoma at the level of the fourth ventricle going out through the obex into the fourth ventricular outflow tract. That's a very characteristic spread of a fourth ventricular ependymoma.